Okay, perfect. So I'm going to start. So my plan was today is to talk actually about the COVID-19 pandemic era from the context of surgical residency. Talking about the coronavirus, basically, we are talking about a virus that already had been known since 1960s. It's not a new virus to us. Yes, maybe different strains had showed different infective virulence severity, and that was evident in 2003, 2015 when we had SARS CoV-1 and MERS. This last year, actually, end of December until the February of this year, 2020, the WHO had declared that SARS CoV-2 is a virus that can cause a severe respiratory disease that can have human-to-human transmission. And taken from that, when this pandemic had been started, everybody actually, or most of the people, including me, were pretending that this virus is just like a flu virus, that it comes, it goes, the mortality is going to be between 1% to 2%. But there was something special when the pandemic started to evolve and to progress. When we started to notice from few studies came from China that we have something called the silent transmission from an incubation period for this virus. The first study came from China, about 1,000 patients who showed the severity of the disease can be 80% will be having mild symptoms like pneumonia. And then we have 20%, like nearly a quarter will need hospitalization. And then 5% of them need the critical care. Now that was at the beginning. That was like talking about January, February. From that time until now, different countries have showed different preparedness and different results actually in terms of admissions to the hospital, admission to ICU, the rate of intubation, the rate of death. And probably when we finish all of this pandemic, we're gonna see that these numbers, all of them gonna be changed when we start like to have the actual real numbers for the pandemic. So the transmission of this disease was dependent on the viral load. It was noticed that the viral load is highly existent in the nose and the throat, and the replication was highly evident in that area. It's kind of different of what we have from the COVID-1, where the SARS CoV-1. The SARS CoV-1 was mainly like in the lower respiratory tract, and then we had the novel asymptomatic transmission. Apart from that, studying how the virulence of this virus started, like actually it's attacked the host cell receptors of the ACE2, which is changed the whole pathway of this virus actually. It changed how this virus is attacking the body. The pandemic has been changed since this virus was able to attack the respiratory systems, the kidneys, the GI system, and the endovascular system. So the pandemic stats and the expectations of seasonal spread is also something we should consider, that it might still staying with us for the next seasons. And then also the second wave of the pandemic, whenever like these mitigation measures have been reduced, a lot of virologists have been expecting that. So talking about the silent transmission, there was a study in the Nature. It came, I think, around February, where there was one modeling study based on the timing of the infection among 77 transmission pairs in China, with a mean serial interval of 5.8 days between the onset of symptoms and each pair. The assumption at that time about the incubation period suggested that the infectiousness started 2 to 2.5 days earlier of the symptoms started. So people were able to transmit the disease before they were symptomatic in 2 to 2.5 days. And then the symptoms, when the symptoms started, it was the peak of the transmission. And then the rate of the transmission was lower after 7 to 8 days of the symptoms. Talking about the pathophysiology, I think I mentioned some about it, like the attacking of like going to the ACE2 receptors. It was identified as the functional receptor for the SARS-CoV-2. And those receptors are highly expressed in the lung, in the heart, in the ileum, kidneys, and bladder. So this is why maybe we are seeing the multi-organ failure in the severely affected patient because of the expression of the receptor in different body organs. Then the main manifestation was like an acute respiratory illness. It's highly expressed in the epithelial cells. There was a study done in Italy, about 111 post-mortem study. They brought like the people who've been identified, confirmed, diagnosed with COVID, and those people have been studied, their body have been studied after they passed away. And what they noticed that the lung has had changes. It does not, I mean, it doesn't be explained only by those people had like an ARDS, but what they noticed that there were small clots in the lung. There was kind of a status of hypercoagulability in the lung. And there was evidence of pulmonary hypertension caused by smaller vascular constriction around the alveoli. Each single element of this in itself can cause like a high morbidity mortality for a patient. So imagine if you have the three of them in one patient. And this is why there was a rapid, like talking to different colleagues from different parts of the world, there was a rapid deterioration. Like you see people, even here, like we see people young, 20, 30 years old, like within minutes, they can desaturate to 65 and 70%. So taken from that, the intubation rate was high at the beginning of the pandemic in different areas of the world, not only like in China or like in Italy, even in the States, actually. And then coming from that, there were a few studies came last month. Some of them were from Italy, some of them were from China, talking about the vascular endothelium, that the hypercoagulable status is disturbed and the coagulation profile is disturbed also in the endovascular system. What is weird in this disease, the hypercoagulable status is not only noticed like in the venous system, like what we see in the severe people who are admitted to ICU. Actually, you can see arterial and venous hypercoagulability in both of the systems. And it's only few pathologies that we know, at least until now, that can give you this manifestation. Talking to the vascular surgeons, our colleagues in Kuwait, here in Canada, in the States, I mean, we are seeing a severe hypercoagulable status of like the large arteries, the large size arteries, which is nothing like we used to. It's something we used to. Then the panel of the coagulation profile is also something we are not used to. Like having high fibrinogen, high D dimer, like one of the D dimers can go to 20,000. These readings I didn't see before. And also the manifestation of the antiphospholipid antibodies. There is a study that came recently that's suggesting there is a manifestation of a secondary antiphospholipid syndrome. It's not the primary, it's a secondary. How accurate is that? Honestly, I don't know. It's not my field. But reading through that, having anticardiolipin, antiphospholipids, IgM, IgGs were high, it can explain in somehow why those people are hypercoagulable. Then there was a witnessed clinical situation in the New York recently where they had 102 cases of children who were presented with a severe Kawasaki-like disease or like a toxic shock-like syndrome. And what is weird about those people, the 100 patients, that 40 to 50% of them were positive for COVID, and the other half, which were not positive, they had the antibodies of COVID. The high percentage of them had the antibodies of COVID. So the question came for the last few days in New York, is that something that COVID is presenting now, or something as a new presentation of COVID? That we don't know. The investigation have been carried, the WHO have been notified from UK. And what in New York they did, actually, they declared a message to the all health systems like around the States. And also they send a message to Europe where like we have 5 countries, UK, France, Italy, Spain, and one more country that are reviewing their cases for the children since the start of the pandemic, to see if they treated people as Kawasaki-like or like as a toxic-like, and they didn't think they were like COVID patients. So what we know now, there is kind of a cytokine storm, like increase of some of the cytokine element, interleukin 6, 10, and others. And there's few studies that coming out that indicating the high level of this immune component can indicate the severity of the disease. And also the finding of the SARS CoV-2 being existent in different non-respiratory specimens specimens like stool, blood, ocular secretions, and semen, it can carry like the thinking, is this pandemic gonna end up in a different manifestation? However, what we should know until now, even that we have some element of a genome or like an RNA in the specimens, we don't have the evidence that these are able to transmit a disease. So I'll try to run over the transmission we spoke about. Like it's person to person, thought to be respiratory droplets, coughing, sneezing, droplet on surfaces, and then the discussion about, is it like an airborne, is not an airborne. There was a study actually done where they grow a tissue culture remained viable and experimentally generated aerosol for at least 3 hours. And I think all the discussion about the airborne came from this study. We don't have the evidence yet, because we have some studies that people have been exposed to COVID patients with the regular droplet precautions with risk of manifestation. Just I want to show this video. It's from YouTube. This is JAMA. It's been published, this video actually, and it can show you how the sneeze droplet, the cough droplet actually spread like in kind of cloud-like. It's something you should consider when you see a patient. The point of this video actually is not to see how virulent is the virus, actually. It's just to see how careful we should be when we see patients. We are like surgical residents and other specialties, how careful we should be when we see the patient. So I'll just try to run it here. Yeah, here we go. So the distance here is like about 110 centimeter. And we can see how the cloud is. And the small droplets can reach actually even like the 110 centimeter and farther from that. On the next part of the video, they actually showed like a higher distance of cough and the sneeze, and where like some of the droplets, see like it's approximately here 23 to 26 feet. Anyway, until now, we don't have evidence that the transmission can go further than the 6 feet or the 2 meters, but this should be taken in consideration. So viral shedding and the period of infectivity. So the interval during which an individual is infectious is uncertain. We don't know for how long you can be infectious if you get the disease. And actually, a few studies came with the different medians of the infectivity period. So the SARS CoV-2 can be transmitted prior to the development of symptoms, as we said, and then you can be symptomatic. You can be like transmitting even when you are symptomatic and after symptoms. The viral RNA level from the upper respiratory tract specimens appear to be higher soon after symptoms onset compared with later in the illness. So they detected, there was a study like that was done in Germany where they detected the genetic information of the virus and the RNA on the light switches, on the door handles, on the discs, for the people who are infected with COVID. And what they realized, what we should mention, what they realized is that having an RNA virus does not mean in the lab you can replicate this virus. And that's something we should take in consideration. So talking about this study, which came from the JAMA, what they did in this study, like they had 9 patients with a mild COVID-19 infectious virus was isolated from the nasopharyngeal and sputum specimens during the first 8 days of the illness, but not after this interval, despite continued having high viral RNA levels. They were not able to transmit after those 8 to 10 days. Another study from the Lancet, which studied like 21 patients with mild illness. They had no hypoxemia. 90% of them had repeated negative viral RNA test on the nasopharyngeal swab by 10 days after the onset of symptoms. Tests were positive for longer in patients with more severe illnesses. So probably what they found is like people who have severe symptoms, they have more viral load. The last study I would show like in this field is about talking, it's like from the Oxford Academic, the clinical features of the disease. They had 56 patients with mild to moderate illness, none required intensive care. The median duration of the viral RNA shedding from nasopharyngeal area was about 24 days, and the longest was 42 days. So like 3 different studies, every one of them talking about different viral shed, but all of the three studies, when you go through the discussion, what they find is the RNA element. They don't know if this RNA element is able to be replicating and causing disease after the symptomatic area. So risk of transmission, we are talking about risk of transmission that is dependent on few factors: the type of exposure, duration of exposure, use of the preventive measures, and the individual factors, the amount of the virus in the respiratory secretions. Then talking about the environmental contamination, we know that the virus present on the contaminated surfaces. Transfers of the infectious virus to mucous membranes can happen through touching the fomites, putting your hand on the or close to the mucous membranes, and then it can go through the body. I would like also to show this study from the JAMA. It's about, in this study they had, it was done in Singapore, where they had the viral RNA was detected on nearly all the surfaces tested. Handles, as I said, handles, light switches, bed, and like handrails, the interior doors, everywhere. In the airborne infection isolation room of a patient. So a patient infected was a negative pressure room, and even that he was a negative pressure room, the viral evidence was everywhere. However, that RNA that was found in the lab, it was not found to be causing any replication, or like the process of showing the process of replication, tendency of replication. And the same study I said, like it was manifested in, was done in Germany. Talking about the clinical features, so 14 days following exposure, with most cases occurring approximately 4 to 5 days after exposure. The median incubation was 4 days upon all the studies. The spectrum of the severity, like we are talking about around 80% of the patient had no or maybe mild pneumonia. Severe disease 14%, and then 5% they required critical care admission. That's just to be mentioned. It was these numbers coming from the Chinese study that was done earlier in the pandemic. Then, if we're gonna talk about, my question is what is the perfect system to practice surgery during COVID-19? What is the perfect system that we should implement? I'm being honest, I don't think there is a perfect system. The perfect system, in any definition, is the system that you can afford in your institution. What resources you have. I don't think like any practice in any country can be applied in different part of the world. So the system that can be showing safety, feasibility, smooth to adapt. We have to have like a system that is smooth to adapt to, and then a unified, effective, and then changeable. So going through a pandemic from the place I'm in, like I remember at the beginning, February to March, you receive like an email or like a new guideline every week. And you get lost until things get stable, and then I don't think that was a weakness in the system. Like actually, it's the changeable system is the system that can survive through this pandemic, because it's an evolving pandemic. The annals of, I'm gonna run over this study from the Annals of Surgery, which was published I think around March, yeah. And in this study, they were talking about the surgical care as a foundation of any health system, with both elective and emergency procedure contributing to the health of our population. However, the stress this pandemic had been put on us was like highly felt. The urgency in the management, the involvement of the multiple staff, the need for high transmission risk procedure, like airway management, intubation. This is something that added like to the burden of this pandemic. So what they said, like our system are generally well designed to deal with the occasional high-risk cases. But what we do with this type of pandemic, the additional strain we presented by high prevalence of the disease, limited resources, staff under pressure. I don't think there is a system, a single system in the world didn't suffer from a shortage of the PPE or a shortage of staff because they get infected or because of any other reason. So the recommendation they came from a surgical point of view is to be prepared for rapidly evolving situation. This is a rapidly evolving situation. You should be ready every day. Every single day you go to the hospital, you should be ready, think gonna be worse. Need to liaise between the different health system authorities in the country itself to know at which zone is the pandemic. Are we still in the confinement area, or like we are different? We are trying to the reopening and reoperating period. Number two, postponing the elective operation immediately. That was at the beginning of the pandemic. So elective surgeries should ideally be postponed before it seems necessary. Postponing surgeries will reduce the unnecessary patient trafficking in the hospital. You want to reduce the number of the inpatient that might get infected from COVID if you can delay those surgeries. Then develop a clear plan for providing essential operation during the pandemic. This should include a plan to facilitate the emergent life and limb-saving surgeries, as well as urgent surgeries such as cancer surgeries and other stuff. And here it should come like our clinical judgment. I mean, a few steps might not be as important as limb-saving, but I mean, having a biopsy from a breast mass that is suspicious, it's nothing like that you should neglect. This something should be looking at and should be scheduled through this pandemic in a timely fashion. Then educate all surgical staff on personal protective equipment and COVID-19 management. All the members of the surgical team should be trained appropriately on how to use the PPEs. And this is crucial. This is extremely crucial. How to do donning and doffing, this is nothing that you do before you're on call once time and you forget about it. No, I mean, under stress, everybody of us will be affected and our judgment will be affected. So it is really, really challenging if you have a really sick patient coming to you, trauma, stab wound, gunshot wound, anything, and you would try to practice your donning and doffing that you did over a video, like in this situation. I don't think that is feasible. Then the culture of using the N95 mask, it's something that we didn't used to use it. I don't think I used N95 like maybe only on once or twice before the pandemic. But then when you try to use the N95 mask, do we know about the fitting, the testing, the shaving of the beard? Are you leaking air or no? Putting N95 mask and like a person like me wearing glasses where like I can see the vapor of my breathing on my glasses, I don't think I'm doing well. And you can have there is like kind of deleterious effect when you think that you are really protected and you are not. So donning and doffing, putting the PPEs, how to use the PPEs, is something crucial. This is something staff should teach senior residents. Senior residents should take the responsibility to teach juniors. And if you have medical students, which maybe is not an advised thing, but if you have medical students, the junior residents should have the responsibility to teach them how to use the PPEs. Then decrease the exposure of healthcare staff. So for confirmed COVID cases or cases where there is an active like influenza symptoms, limiting the operating theater staff to be essential members key. The discussion about the trainees, there was a markedly reduced number of trainees in the OR everywhere, like every part in the world. In particular, should not be involved with cases unnecessarily. And then as COVID-19 becomes further established in our communities, asymptomatic patients who are carriers will increasingly enter the health system. I mean, now we have the suspicion, but when things ease down, we will see a lot of asymptomatic patient that comes for different things. And then at that time, we should be careful dealing with everybody. The last thing, keep the surgical staff out of the hospital and self-isolating at home when they are not needed as a key measure to preserve our human resources. This is an advice that was taken, I think, like most of the guidelines and the recommendation I went through with my colleagues for the last few days. Most of them, they had this indication that if you don't need this part of the team, keep him at home, put him on the schedule, bring him where you need him. So talking about how to develop a dedicated COVID-19 operating space, they were talking about design a specific operating theater for all COVID-19 cases. So you have, for every on-call, you have 2 rooms, this room for COVID patient, this room for non-COVID patient, and then you have different teams running both rooms. Rooms should be out of high traffic areas. Like if you have the facility that can offer a room, afford the room, which is like kind of away from the trafficking area, completely empty from all non-essential materials, instructional posters everywhere in the room, and then coming to the no unnecessary items should be brought into the operating theater. This is a must for us as a surgeons. We used to go in having, like, if you work in a hospital where they have pagers, they have like the spectras, they have phones, we bring everything and put it on the table and go to operation. When they start to intubate a patient who is a COVID patient or suspected COVID patient, this aerosol procedure will transmit the virus everywhere in the room. And then you have your phone, everything is, so you have one of 2 options. Number 1, if you can't, don't bring them in the room. Number 2, if it's a must, you have your pager, which is like you are on call and you can't leave it out, then put it in a plastic bag and then leave it on the table away from the surgical field. Apart from that, using the disposable caps and shoe covers, And then all traffic in and out of the operating theater should be minimized. There is like a huge rule for the nursing staff during this pandemic, how they should control the pandemic in the operating room. The in and out trafficking in the operating room is not acceptable, and the door should be closed most of the times. Then they were recommending that patients should be recovered in the operating theater, extubated, and then depending on the institution guideline, how long he should stay in the room until things are clear, 25 minutes, 30 minutes, it depends on the institution. And also, they recommend that surgeons before extubation should leave the room. And only the respiratory technician, the RT, and the anesthetist should be in a full PPE gowning and like protective measures to stay in the room, unless if the surgeon existence is required. The path of the patient to and from the operating theater should be kept clear. This is a really successful practice where you should when a COVID patient is coming in and out from the OR, the corridor should be empty. And honestly, working in a different hospitals for the last 3 months, sorry. One of them was a pandemic hospital. The other one was like a tertiary trauma center, but not a pandemic hospital. The measures are the same. When a COVID patient coming out, there is a security team that prevent anybody, physician, patient, visitor, anybody, nobody is allowed to go through that corridor until the patient is cleared out from the room. And then dedicated team members to manage the COVID-19 cases each day. So some of the hospitals were implementing the idea of airway team. So every intubation in a single day will be done by a single anesthetist and a single RT, respiratory therapist. And they can have a backup team, but any intubation on that day will be done by these 2 people. And this is only an idea. It's not like a must. And then the operative team also, it should be like a single team that deal with the COVID patient and does not, if it's possible, does not mix with the other teams. And then the nursing that running the OR. Then coming to this topic that I'd like to talk about, what are the priorities for surgical residency? The surgical residence programs in the early phase of the pandemic. This is something was highly negotiable. I mean, personal safety is a must. There is no reason, there is no single reason in the world you are legit to expose yourself to the risk if you were offered the PPE and you were offered the training. We should protect ourselves. And as we said, donning and doffing is not something that you review on the time and master it. You can't do that. Actually, you should do it kind of like on a regular basis to remind yourself. Then the mental health. Mental health is not something luxurious. I mean, nothing that is kind of spoiling the healthcare worker or like spoiling the surgical resident. It's not. It's a must in most of the residency programs. And then planning on a personal level. How you will go through this pandemic should include the chronicity of the pandemic worldwide. Any decision you take, how you're going to protect yourself, you should take into consideration the chronicity of the pandemic. Working for long hours without rest increase the physical stress. All of these adding, and also if you add the self-isolation from families, from partners, from kids, all of this can reflect on the physical and mental health. We hear scattered cases around the world about healthcare worker who they committed homicide, suicide. And we see that. I mean, the last news about like a medical student who passed away 2 days ago because of the suicide. So we should, if we are gonna plan to self-isolate from partners and close relatives in the one household, that should be taken care of. Nobody should oblige anybody to take the decision, but that should be taken carefully, putting in mind the chronicity of the pandemic. There's nothing that's gonna finish. We work in the hospital. There's not gonna finish next month or maybe the month after. We don't know. Honestly. So we should put in our mind the chronicity of the pandemic and also the principle of the new normals as a healthcare worker. People are talking about in the community about the new normal. So I think we should, and ourselves, we should think about the new normal. There was a study that ran in Italy, if I'm not mistaken, yes, and it was like between the urology residents who have been trained in Italy. I think it was published around March. And reading through different articles, including this one, the learning process and the education through any residency program around the world have been affected hardly. People in this study, they showed that what they were saying that residents were joining the clinical skills and the OR opportunities about 70 to 80% before the pandemic. And since the pandemic started between February to March, the learning outcome through going to the operating room was nearly zero, nearly nil. So the junior residents were not able at all, like for the first 2 months, to go to the operating room. And then for the senior resident, like it reduced to the 40% from 80%. So this is something that we hear about and we feel sorry about it. I mean, surgeons can't live without surgery. What's about surgical residents who they have only 5 years to learn all the skills that they need to start their life as surgeons? There was a study that was published in the Journal of Surgical Education, and it was addressing the general surgery resident concerns in the early phase. Let's start with our first poll question. I'd like to ask a question. What we as resident think about the thing that is a concern to us. Let me put this one, just a second. Yeah, so I'll put like a poll question, number one. It's what are your concerns as a resident or surgeon in this pandemic? What is the most single thing that is annoying you? What you are thinking about when you talk about this pandemic? I'll give it a minute. So the objective in this study was to determine the concerns of general surgery residents as they prepare to be in front lines of the response against coronavirus disease. And people have been acted differently. I hope if you guys can see this, and if you are able to answer it. Okay, I'll try to finish it now. So we have 91%. Do you see the results? For some reason, I can't see the comment. Shaima, you can text me if you see the results. Yeah, I think this is the chat. Yeah, okay. So here we go. Yeah, so 91% had thinking about the safety and these measures in the family. So all right, so let's review. So in this study, as I said, this is what they were thinking about, and honestly, 100% of the people, they were thinking about the health of their family. The 63% of the people were thinking about transmitting the COVID infection to their patients, and 50% anticipated overwork for taking care of high numbers of patients, and the risk of their acquiring COVID-19 infection from their patients was 27%, the least. So this is something stressful. I mean, you work in the hospital, see asymptomatic patient, you go home, you don't know if you carry something from outside. And I'm talking about myself. I'm not sure like if I can stay 5-6 months away from my family. I mean, I don't know how that is feasible. So this was the study that showed the main concerns for any surgical resident or like the healthcare worker. So how to be prepared as a resident? We are as a resident, how we should be prepared through this pandemic. We should work on the protection of ourselves, our colleagues, our families, and patients. We are the guardian of the hospital. If the transmission gonna go out, it's gonna go out through us. So reduce transmission through direct contact to patient. We know like it's a person to person, and we know like FOMIT has a role in that. So ask yourself every time you go to examine the patient, and that's different from surgeon to surgeon. But I mean, this practice has been done in different parts of the world. On a personal level, I'm talking like to different people from different parts of the world, they do the same. Do you need to examine the patient? This is a question you ask yourself every time you go. So if the patient was examined by one of your colleagues, if you trust him, do you want to repeat the examination? This is something you should ask yourself. Number two, if you have like a CT showing a simple appendicitis and the emergency staff should tell you this patient is tender, and he will be tender right lower quadrant, do you want to re-examine the patient? This is something we should discuss. I'm just gonna mention, and this is not just like to open our mind. Now, in different hospitals, there is a practice that you take the history from the patient over the phone. And if you are satisfied from the CT finding and the examination from your colleague, you don't go to examine the patient. If he, and then it depends on the patient positive COVID status, if you're going to go to the OR or no. Then collateral history. Should we more be dependent on the collateral history? If you were the person who, the first one who saw the patient, try to take a proper history, and that will add to the benefit from everybody else going to come to see the patient. Because if you see a patient who have been seen properly and the history was taken properly, I don't think you will need to ask the patient more questions by sitting in the room like for 15 minutes, 10 minutes. I think you will have maybe one or two questions, and that will minimize the exposure to the patient. Careful study to each case with differential diagnosis and proposed treatment plan prior to direct contact. Before you go to the patient, if you can gather all the information to put a plan for managing the patient before you see him, that will reduce the time you're going to spend with the patient. Review the imaging properly. See your imaging very well before you read the report, even before you go to see your patient. And that will add to minimizing the time you expose yourself to the patient. Reduce personal belongings when examining the patient. Don't go to the patient with the phone hanging outside or like with pens. You go in a PPE if he was a COVID patient. You maybe spend 1 minute inside to examine him if you have to. And then you go out, you take your stuff from outside. If you can't leave your stuff outside, maybe then we should come like with a novel thing. Put your phone like in a plastic bag. I mean, do anything that we see on the internet on a daily basis, just to protect ourselves from having something that goes in and out from the patient room, apart from our physical bodies. Reduce personal belongings, as we said, this one was mentioned. The novel ways to protect self-belongings, like disposable pens, moving to paperless documentation, if we can to do that, that will be crucial actually. Taking history over the phone, as I said earlier, or over a speaker, that's something was being practiced in a different hospital that I worked in. Then talking about PPE, as per local institutional or universal guidelines, donning and doffing, like this is the third time I'm talking about it. Doffing, it's not something easy, believe me. PPE person, if you have something, I mean, it depends on different system you work in, but usually like the nurses, and they have and senior resident and staff, they have well training about using the PPE. So if you have a PPE person around you to check if you were really protected, that's something crucial. That's something to check if your neck is covered, if your back is covered. That will be something crucial. And then N95. N95 should be tested. You should be tested even if you lost weight. I mean, if you have N95 size this year and then you lost kind of more than 30% of your weight, I think your N95 test should be refitted based on your institution guidelines. And then how to remove your N95. It's not something easy, especially, I mean, I'm talking practically. If you wear glasses and you don't want to touch the front of the N95, I think this is something that you should train yourself to do it, not when you see a patient, something before you go to the patient. Working hours and on-call shift system. So this is a study that Oxford Academic for Clinical Infectious Disease. I think this study was done in China, in Wuhan, if I'm not mistaken. Yes, in China, in Wuhan. And what they show in this study that the contact transmission is one of the main routes of the SARS CoV-2. Transmission from patient to healthcare workers usually follows contamination of the healthcare worker hands after touching either patients or the fomites, whereas hand hygiene is considered the most important prevention measure. It's like hand hygiene. And then they mentioned the talk about the working hours. Working hours is different from system to system around the world. We should come with a practical, appropriate working hours that can protect the healthcare worker and can protect the patient safety in the healthcare facility. So moderate working hour benefit the health and safety of the healthcare worker. This was their part of their conclusion. And then what they saw, I'm not sure like how right is that, prolonged working hours, more than 10 hours per day, possibly, as they said, increase the risk of the respiratory infections based on the results. I don't think the study was kind of like blind. It was a cohort study. So that's something we should just think about, using the physical stress, how we should deal with the working hours. Then we're going to come to talk about the different hospitals around the world adopted different on-call shift systems. So these are just ideas. Again, it's not something that you should implement from today or you come to discuss it. It's something that if you think you can protect yourself with a better system from now on, just have this idea and think about it. So what I saw in different recommendation and different articles, there were a tendency to divide the large team. There is no large teams in the hospitals. Honestly, I don't remember that you see large teams rounding now, because students are not coming and the large team have been divided. So if you have the capacity, and it depends on how many patients you see, if you can cover your service or no. But I talk about like a trauma center, like a level 1 trauma center in a large town that has a huge population, nearly about 4 to 5 millions. You can cover the hospital with 2 to 3 residents in a shift. And that's only like a witness thing. It's not something that you should do it as a must, something that you consider. Then if you can implement the idea of a tag team, if I'm A and I have like my colleague is B, and we have C and D other people, if we can put our schedule that A and B will stay the whole period of working together, so we can avoid transmitting. If I was infected or I was a carrier or like B was a carrier, we can infect each other and maybe will not spread to the other part of the team. So the tag teams, if you're gonna go on the call schedule, you tag yourself to somebody else. Then the backup team, you should always have a backup team, because if you're gonna divide, trying to increase the capacity of the team, try to save the resource of the human resources, then you should have a backup team for every night that one of the patients, one of the doctors will be infected or like will be a carrier or he tests positive for COVID. Then alternative working period. So as I said, different articles have different suggestions. We worked on different systems. Some people are doing like 2 weeks on, 2 weeks off. Some people are doing like 1 week on, 1 week off. It depends on how you can afford that. But most of them, they were kind of trying to reduce the accumulative exposure. There is like the onset, the one-time exposure when you see a patient, and there is the accumulative exposure. When you stay in the hospital for 10 hours, 11 hours every day for 2 weeks, it's gonna kind of equal if you stay 24 hours every other day in different. So there's kind of accumulative exposure that you might carry the virus and you don't know about. Then testing. This is crucial actually, and this is something that we should consider hardly. If the physician is symptomatic, there is no reason in the world that he should not be tested. He should be tested, because he's a healthcare worker and he's needed in the healthcare system. You will need him. And instead of like putting at home for 14 days and you don't know if he was positive or no, then I think he should be tested. Then after exposure, people, if you get this is what I'm carrying the articles and the guidelines. If you know you were being exposed for a really COVID patient, you have the right to be tested. And then some of the sites at the hospital, like ICU, and the COVID floors, they get tested in different parts of the world, like regularly. You finish your shift of 1 week, period of 1 week or 2 weeks, you will be tested before you go home and you take your break. So I'm showing this American College of Surgeon guidelines that was published in March. So what is crucial in this is just like the first statement. The information provided should not be considered rigid guidelines. It's just like to guide you. It's not like, should not replace your clinical judgment, nor the information intended to impede with the development of consensus regarding institutional or local approaches the treatment guidelines. So their general principles was, and I'm going to try to run over them just because of the time. The goal is to provide timely surgical care to patients presenting with urgent and emergent surgical condition. There is no substitute for sound surgical judgment. Procedures and operations should be performed for a definitive treatment. So if you delay the procedure, that will affect the patient, that he will come again to the hospital, maybe you will consider doing the procedure. If you think not doing the procedure, that will prolong the patient hospital stay, then you should go to a definitive treatment by doing the procedure. Patients who have failed attempts at medical management of a surgical condition should be considered for surgery. So you tried like uncomplicated diverticulitis, appendicitis, whatever, and the patient is not improving, then you should consider something else. Multidisciplinary shared decisions regarding surgical scheduling should be made. So also running over this, I'm not going to go, I mean, it's online, you can access it. But as an example, I mean, if you have acute hemorrhoidal thrombosis or necrosis, just to spare the pain of the patient, most acute hemorrhoidal condition can be managed non-operatively. Large number of the hemorrhoidal cases can be managed like in an outpatient setting. And only emergency surgical procedures should be generally preserved for significant bleeding or for a severe disease. And also that goes for the clinical judgment of the surgeon. Perianal abscesses should be done under local anesthesia. Large one of them should avoid like the soft tissue necrosis, go to the operating room. If you can implement the spinal with anesthesia or like intubation, then it comes between these decisions between you and the anesthesia. The appendicitis, if it's uncomplicated and with no appendiculate, maybe you will consider IV antibiotic followed by transition to PO antibiotics. And then if it's complicated with appendiculate, the decision is up to the surgeons for the high failure rate. So some surgeon will still go with the IV antibiotics, PO antibiotic transition for the appendiculate. And there is a high failure rate that goes maybe up to 50%. And then you should carry the risk if the patient comes back, because there is a 50% maybe will not come back to the hospital. Complicated appendicitis, IV antibiotics, and then until clinically improved, if there is an abscess that be drained, should be drained, and precautions should be taken through drainage. And then for the biliary disease, chronic cholecystitis, cholelithiasis should be managed pain-wise. Surgery delay if feasible. If you think you can delay the surgery for elective manner, do it. And then for crescendo cholecystitis, they were suggesting doing a lap chole. Acute cholecystitis, low-risk patient, you can do the lap chole and try to reduce the hospital stay as much as you can by going through the ERAS, the enhanced recovery. So patient should go home as soon as possible that he's tolerating the diet and pain is managed. And then for the high-risk patient, you can consider IV antibiotic. If failed the IV antibiotic, what they were suggesting, controlling the infection by the pericholecystomy tube. Then talking about cholangitis, IV antibiotic, what they think if the stone was not obstructing and the patient was responding to the IV antibiotic, maybe you can do the ERCP in elective manner. If patient indicated to have a lap chole for cholecystitis, then what they were suggesting is like to consider the pericholecystomy tube, and also that will not replace the surgeon decision or like the surgeon judgment. Then for the diverticulitis, the same. The simple cases can take PO antibiotics, goes home if they are to related pain, and then they are fitting the criteria for home treatment of diverticulitis. If they are not and they have high Hinchey score diverticulitis, then maybe you should consider percutaneous drainage. Phlegmons should be drained. And then comes to this crucial thing, the follow-up. When you try to do any of these conservative management, you should think about the follow-up. Okay, so you can what the hospitals were doing, some of them were doing home call. Next day you call the patient, you can video call, or you can do clinic follow-up. And just to mention, like the large number of clinics here are run by the video call, virtual. You can see the patient, and if you think you need to examine the patient, you ask the patient to come to the hospital. If admission is indicated, patient disposition should be considered early. There is no recommendation to keep the patient in the ER if he's COVID patient or suspected COVID patient. Then COVID triaging testing, some of the hospitals, they implement that for any mild to moderate suspicion patient, like with symptoms based on the social history, they get tested. And the admitting service should be protocoled early. I mean, it depends on the institution you work in, but surgical or medical or COVID patient or suspected COVID patient should be go to the indicated ward. So there is like a COVID ward or no. Then the treatment consent, they were recommending that it should include the risk of COVID-19 transmission. Patient should know that he might pick up the disease inside the hospital. The transportation we spoke about, clearing the corridors, use like the help of security. Nobody should be allowed like through transportation to be near the patient. In patient care in the context of COVID-19 patient, that's crucial. I think we should have like a specialist to talk to us about the role of the anticoagulation. There is a huge discussion about the anticoagulation now. Should be like therapeutic level, should be like a higher dose level of low molecular weight or of the heparin infusion. I will leave that for the moment, but it's kind of if you forget the anticoagulation for a COVID patient, it's like you are forgetting antibiotics for a cholangitis patient. Then reduce the hospital stay as much as possible. I think this is one of my last slides. If patient is going to the OR, consent, including picking up the disease in the hospital, PPEs. There was a discussion between SAGES and between the ACS about the laparoscopic varus open. I think we should consider harm and benefit in this situation. Laparoscopic can decrease the hospital stay for the patient, but at the same time, there is a high risk of, there is a considered risk for aerosolizing through the vapor of the CO2 or like the surgical vapor, the smoke. Minimum number of scrub surgeons and assistants, we mentioned that before. anesthesia precautions through the aerosol generating procedure, using muscle relaxant, the way of ventilation, the plastic box, whatever they are used to. And then protection / prevent personal belongings, as we said. If you can avoid, bring your things inside the hospital. And then according to SAGE's laparoscopic guidelines to reduce the risk of laparoscopic surgery, if you can insist on the minimum pneumoperitoneum, small port site incision, like to avoid the leakage around the port side. Avoid ventilation during surgery. If you have a smoke or vapor inside, avoid ventilation as much as you can. Use the suction. Low electrocautery use or setting. And then a smoke evacuation system should be considered and used. Hand-assisted surgery, it carry high risk for CO2 leakage. So taking specimen out after you finish the surgery, it should be done in a way that after you evacuate all the vapor inside or like the air inside the abdomen. And then extubation and disposition. I'm going to talk about disposition in one line. Patient should be dispositioned, like the decision of disposition should be taken before going to the OR. This patient going to come out, going to be extubated inside the operating room, and then either he goes to the ICU or he goes to the COVID floor. I'm going to quickly go over this case. I have two cases to finish with. So case number one, and by the way, these are real cases, but I just like manipulated the information so it can fit the Kuwait surgical board. So 57 female presented with 4 days of epigastric pain, severe nausea, vomiting, 1 spike of fever that started 4 days after the abdominal pain. Past medical history, osteoarthritis, open coli. She had no history of allergies, and social history, she is married, lives with her family at Mahbula, works as a cleaner in the hospital. So on physical exam, she had a soft abdomen, tender epigastrium. The biomarkers were, the biochemical biomarkers were white cell count was normal, hemoglobin 113, platelets 150. Her lipase was elevated twice normal, 95. Her bilirubin profile was normal. Liver function tests were normal, and she had normal Chem7 or RFT. Can I ask, what do you think is the diagnosis? This is the CT scan that was done for the patient. And again, for some reason, I can't see the answers. Sorry, just give me 1 minute. Okay, so anybody have an answer? No one? Typing? Lipase twice normal? With the CT scan? Sure, I will show the CT scan again. So this was the history. This is the CT scan. This is like the head of the pancreas, and then you have the rest of the pancreas there. Don't want to take a long time, like whatever comes to your mind. Okay, pancreatitis, legit. All right, anybody wants to, before you go to see the patient, would you like to do anything based on the history? Through the imaging, would you like to see anything before you go to see the patient? Something that might change your pathway of dealing with this patient. Chest X-ray, Ahmed Shimali, excellent. So what I did at that time, honestly, I didn't see the chest X-ray. What I did, like, because when they take the CT scan, they go to the upper cuts of the lung, or the lower cuts of the lung. So actually the CT scan of the lung was showing kind of peripheral opacities. The patient, when was seen and examined, she had 0 respiratory symptoms, 0. But based on the social history that the place she was working and she came with was like, there was kind of an outbreak there. And she said she was not exposed to any of the sick patient, and she doesn't even work on the floors where the patients were sick. But based on the CT scan, we had high suspicion that the patient is carrying COVID. And we limited our examination for like only 1 minute seeing the patient, and then we asked the COVID team to see the patient for admission. And patient was not delayed until the result comes out. She went to the COVID suspected floors, and when the result came back COVID positive, she was COVID positive. She went to the COVID floor. Case 2, just to mention, I mean, for that patient, we know that there is some expression of pancreatitis that can comes with COVID. And the patient came after 4 days of history. She was able to tolerate diet. So if she's grade 1 pancreatitis, Balzahar or no, God knows. But I mean, at the end of the day, she didn't need an inpatient admission from a surgical point of view. She needed because she had fever and they want to sort out this kind of pneumonia. So I'm going to go through the second case quickly, and I'm going to finish. 59 male, history of seizure, fell from on height. He hit his head to the floor, and he came with a large frontal head lack of bleeding profusely. On arrival, patient airway was intact. He doesn't respond verbally. Heart rate normal, blood pressure normal, respiratory rate normal. Saturation is not here, but I remember it was 96, and the temperature was 37.6, 37.7, sorry. His Glasgow Coma scale was 10, and the pupils were bilaterally pinpoint. No other significant injury, and the secondary survey was negative. Anybody has suggestion what is next? What we should do next? Head CT scan, okay. Yeah, perfect. So head CT scan. Actually, like, as we said, from different institutions, we had different things. So a patient came with a low GCS. We don't know the mechanism of injury, and the patient, since the pandemic, most of the trauma patients are getting pan CT scan. So this patient went to a pan CT scan. That patient went to status epilepticus. Oh, that's a good point. So patient, this is real. Huh? So patient went to status epilepticus before we move to the CT scan. What you would like to do? You are at the trauma bay. Patient got this history of trauma, GCS 10, Glasgow scale of 10, secure airway, excellent. So the patient got intubated, excellent, yeah. So thank you so much. Patient got intubated because of the low GCS, because to protect the airways also, and for the status epilepticus that he didn't respond. After intubation with the muscle relaxant, was well. Now, during intubation, you are in the trauma room. Did anybody of us think about the precaution? What kind of precaution we should take? Now, you didn't intubate the patient yet. You are in the room. It's a negative pressure room. You don't want to go out and in. You want to minimize as much as you can. PPEs. Okay, what's about the N95? Did you wear it before you go to the trauma bay? Hamar Gabandi, excellent, 95. Yes, you should, yes. So the recommendation was put any patient, trauma patient with reduced GCS that you indicate, or the trauma team leader, the TTN, or like the trauma surgeon, the senior resident, whoever was in the room, he thinks the patient gonna get any aerosol generating procedure. So intubation, that the airway team gonna take care of it, but don't forget, we as surgeons, we do the chest tubes. We put lines, the subclavian lines, the jugular lines, central lines. So if you think there is any kind of aerosol generating procedure going to be done, the PPE N95 should be wearing before you go to the negative trauma room. Nobody should go in or out. It's only for people. And then when you come to assess your ABCD, you should use your ultrasound instead of them. So pan CT scan, instead of stethoscope. Pan CT scan was done. There is no element of TBI. There is some changes from a previous surgery he had, and there was no solid organ injury. Anything you want to see in the CT scan? There is no solid organ injury. There is no TBI. Anything you would like to see in the CT scan before you dispose the patient? Chest, excellent, chest, yeah. And this is the CT of the chest. Yeah. The CT scan was done. Patient suspected COVID. He went to the intensive care unit, taking full precaution of COVID patient, and the test came positive after a few hours. He was a COVID patient. So these are the regular bread and butter general surgery cases that you see, and then You should be very careful when you do this. Future consideration, when to go back to normal, that thing should be considered later. When to return for schedule elective surgeries, when to look back to optimize residency training goals. This is very important. And I think at this time, just an advice, the education should not stop, even if we can do it virtually or if we can do it as we are doing now. One of the consideration was, will the video or the virtual clinic remain after COVID-19, just to reduce the burden on the healthcare system? Why you should see like 50 patients outside your clinic if you can see like 25 of them over the phone? You don't need to examine them if you can. And then should we think of non-COVID-19 hospitals to resume the operation? I'm going to finish and I'm going to end with this one, with this like quote. We emphasize on the importance of leadership, adaptiveness, and the flexibility when building surgical teams, caring for COVID-19 surgical patients, and considering multidisciplinary team approach. I quote this one from the guidelines of the Kuwait Association of Surgeons and the Women Surgeons of Kuwait. This is one of the excellent said that I ever read. The leadership should come from us. We are, as a surgeon, we take the hard decision inside the operating room. And this guideline should be read by every single resident staff and should be discussed like in all the institutions at Kuwait. This is a really well done. And I'm very thankful to the mentors and to the colleagues. They worked on that. This was my references and I finish here. We can't hear you, Shema.
Yes, sorry, my mic was mute. So I was saying thank you very much, Dr. Abdulaziz. Thank you for this wonderful updated presentation. It was definitely beneficial for every one of us. I have received many messages from attendees that they would like to have a few questions. So if you have time, Abdulaziz, we will give them the chance to ask questions. I will ask the attendees to raise thumbs if they have questions, and we will try to select as many as possible. But you know, we have a limited time.
Just what I want to mention before answering, like me as you guys, I learned when I did my presentation, and I learned through the process that we went through. So I might not know more than you, but maybe I can help from what I saw and from the discussion that I ran through my colleagues around the world. Yeah.
Okay. So I will allow Dr. Sulaiman Al-Mazidi, as he raised his thumb, to ask the first question. Dr. Sulaiman, we can hear you.
يعطيكم العافية. Thank you so much, Dr. Shema, for this amazing platform. It's very informative, and I feel like it's not only for residents. And I'm a specialist, I'm sure there's consultants. I learned a lot, Dr. Aziz. Thank you so much. مساك الله بالخير أول شيء. I hope you're safe in Canada. Amazing lecture. Wallah, yani you gave us a very nice summary of everything. Just a few points. I think you mentioned something very important in the beginning when you said and the research is still new and it's going to change, and we're seeing that. احنا بالجابر group we're writing papers about the first 1,000 cases in Kuwait. Kuwait is different and unique from the rest of the world in that the first 1,000 consecutive patients were all admitted to the hospital. In contrast to China and the US, where the publications there, usually patients hospitalized and included in the studies are the more severe patients. So we're realizing in most of the patients, over 90% are actually very mild disease, only 1% mortality. It's actually, as you said, the time will show us the true, the true impact of this disease, I think, with time. Two quick points I want to mention. Number one, you mentioned smoke evacuation. I think that's very important in the operating room, but I think what's also important is differentiating the different techniques of smoke evacuation. If surgeons use the simple suction, they're in danger of spreading the virus all around the room. SAGES has a nice table. You mentioned SAGES in your PowerPoint, but I think all the surgeons should have a look at that table, and it shows you what kind of surgical evacuators have HEPA filters that can be used for COVID. The second and last point, عشان ما أطول, one thing that I think can be incorporated into operating rooms around the world is augmented reality. Jabir, what we did, we had the advantage and disadvantage of being the first COVID hospital. So we had a heads up before everyone else. we got a device called Proximy. It's basically augmented reality system. It's a mobile tower like the laparoscopy tower that connects. There's a camera outside for open surgery, and it has a connection to laparoscopic surgery. And the surgeon operating can actually be connected to consultants outside. So it decreases the amount of surgeons in the room, and they can see him at the same time. They can point their hands on his screen so he can see what they're pointing to. And we did that for a case with Dr. Umar al-Sharif. He had a complicated case, and me and Dr. Salman al-Sabah were using our hands, and we were seeing what he's seeing, and we were pointing out, and we can draw and give advice. So I think that's something that can be utilized. Well, thank you again so much. Well, sorry for taking a long time.
Suleiman, thank you, Dr. Suleiman. Suleiman was one of my mentors when I was young in the medical school. Just to mention, yes, I mean, I'm not a virologist, but reading through everyday studies, there is a different pattern of the disease. Some people, they came completely asymptomatic. Some people, they come like highly symptomatic. And we are seeing that even in Canada. I mean, we have people who had symptoms only for 1 day or no symptoms at all. And I think probably in the future, we're going to see the epidemiology different with the races and with how you can carry the risk factors for the antiphospholipid or different. But what I would want to say, I was so proud, and I mentioned that like in front of you all. I was so proud from the beginning of the pandemic, and I honestly was mentioning all the measures that Kuwait took at the beginning to my colleagues here, and they were impressed, honestly. So if we have the money, if we have the resources, and if we have the people who actually are leaders in the field, why we don't do it? Actually, Kuwait should take the leadership in this one. We have the resources, and I'm also grateful for our colleagues in Saudi Arabia. Like in Saudi Arabia, the things there also like is excellent. So I'm proud of my country, actually.
Thank you, Dr. Abdulaziz. Thank you for your time. Thank you for everyone who attended this session.